Hello, and welcome to our fourth lecture on ovarian tumors. This is Clues to Classification aimed at beginning trainees in pathology and perhaps those preparing for boards. Our cases drawn from the files of the Digital Anatomic Pathology Academy and the University of Oklahoma Health Sciences Center, which is where I'm located. Today's topic will cover germ cell tumors, which are not the most common, but certainly in certain age groups not uncommon, particularly in the first few decades of life. So the most commonly used classification would include those that are teratomatous in nature, which can be both mature and immature, and the germ cell tumors, Disgermonoma, yolk sac, and embryonal carcinoma, as well as gestational type of carcinomas that are of non-gestational origin, Choreocarcinoma, and various mixed types and other much less frequently encountered lesions like gonadoblastoma and so forth. We won't cover a whole lot of those and focus on the things that you're going to see in your practice and likely be encountering on various examinations. So the most important thing to remember is that these are derived from pluripotent germ cells and ova or sperm or some combination of these two. So that makes for a very broad array of morphologic patterns, as we've indicated here, and leads to certainly at times a confounding challenge in differentiating the appearance of these lesions, one from another. Not so much one from another within the category of germ cell tumors, but between germ cell tumors and sex cord stromal tumors, between various germ cell tumors, metastatic tumors, and other tumors that can be encountered here. So beginning first with mature teratoma, these are very common and again are usually encountered in younger patients, although occasionally they will persist into adulthood and even postmenopausal states, because by and large they are not symptomatic. They don't grow or expand, rupture, or cause other problems in most cases. They're usually cystic and readily identified grossly because they have a combination of cutaneous structures that often includes hair and sebum, making these the quintessential dermoid cyst type of lesion. But they can be complicating because at times they will have neuroglial implants both within the lesion and occasionally extra ovarian sites within the abdomen and so forth. So that can make things certainly more interesting and raise the consideration of metastatic lesions as well. So here's a nice digital slide example of one of these lesions. And as we see at low magnification, it's got fat. We see some sebaceous tissue here. We see various glandular tissues, maybe a little bit of neural tissue over here, some lymphoid and epithelial type structures. Right at low power, we can see that this is a mixture of tissue types. So as we go into higher magnification, we can see there's collagenous tissue, and here we see a simple type of epithelial lining, maybe slightly squamoid. As we look around here, we see some debris and some histiocytic reaction, perhaps due to loss of the surface epithelium. Looking around a little bit further, here we see the fat and, importantly, adnexal structures, again indicating that this is not just a fatty tumor or fatty lesion from the omentum or something of that sort. Lots of these adnexal structures can be found. And most characteristically here, you see the sebaceous glands, the squamous keratinization. Maybe this is a hair follicle or something of that ilk. We'll come back to this tissue later. We also see over here more of this tissue, and here we can identify quite nicely a very fibrillar type of tissue, low cellularity, characteristic of neuroglial tissue. Now, this is fairly mature neuroglial tissue, and so it doesn't enter into the consideration of immature teratoma, which we'll cover later. But notice we can have pigmented cells. So you can see at times retinal type tissue, choroidal type tissue, other sorts of pigment producing cells that may be associated with this as well. So a nice example of a mature cystic teratoma with several germline elements present, neuroectodermal, and epithelial, and mesenchymal. Immature teratomas, by definition, are composed of multiple germ-line layers, but are non-mature. So they are non-adult type tissues, the kinds of things that we would expect to see in a developing fetus or embryo. Because these are potentially malignant and metastasizing lesions, we do grade them, and that carries over into prognosis. Grading is largely based on the proportion of immature neuroglial tissue that is present. Essentially, 1 or less than 1 low power field, 1 to 3 low power fields, and greater than 3 low power fields composed of immature neuroglial tissue constitute the break marks between grades 1 and 3. Now, you'll immediately recognize that those are not very sharp gradations. And may depend on some degree of inter-observer subjectivity. And that's one of the problems we encounter with this lesion. So here's an example. Again, we can see at low power a combination of stromal, some epithelial, and then here we see some neuroglial type tissue. So we'll take a look at the epithelial component beginning in this upper left corner. We see that here we have again, a sort of neuroglial type of tissue with a vascular network, some vascular proliferation, and some blue cells. We don't usually see those. That's an indication of a more immature type of tumor and would put us on the alert immediately that this could be an immature type of teratoma. Now, this might also raise consideration for lymphoma and so forth, but as we look at the remainder of this tissue, I think we'll see, here we see more mature neuroglial tissue. Here's some more slightly immature tissue. And you can know it's immature, especially if you begin to see rosettes. Now, we're not seeing those here, but this is still quite cellular in this location. Here's an immature epithelial structure with sort of clearing, and here's some squamous epithelium surrounded by neuroglial tissue and maybe a little bit of neural tube type of differentiation here. So there is variable kinds of differentiation here. Over here we see some muscle tissue, various epithelial components, mucin-producing epithelium, typical of varied teratomas, squamous epithelium, and so forth. And then we come to this more almost serpiginous or cerebellum-like tissue. And we can see here, again, we have the small neuroglial elements, a little bit of necrosis, and even in a few areas, I believe here, there were some rosette-like structures beginning to form. I think here's a couple of them here, one here, and so forth. So a nice indication of immature glial tissue here with immature rosettes, immediately juxtaposed to some squamous epithelium and so forth. So at low magnification, here we've got 1 to 2, maybe 3. This would be a grade 1, maybe a grade 2, depending on other sections, type of immature teratoma. And I think we've done a video specifically on this case elsewhere. Here's another example of immature tissues. Here we see more complex epithelial elements. Here, sort of associated enteric type epithelium with a lamina propria type of tissue, some surrounding muscle organization here. So it's really almost organogenesis type of lesion. But here we'll note that there's a little island or two of immature cartilage. So this is an immature teratoma, but it would be a grade 1 lesion because there's really no degree of immature glial tissue. And we would, of course, look at each of these more cellular foci to make sure that None of them were glial in nature. And you can certainly come back to these slides. We'll post the link to this presentation online so that you can study these digital slides yourself and come to your own conclusions as you find whether these are neuroglial cells or, in this case, lymphocytes. Now, the necrosis in these lumina raises consideration of a secondary somatic malignancy. And so that would also be a concern here to make sure that this epithelial component is not becoming malignant. However, the organization with smooth muscle coat and so forth, I think argues pretty forcefully against that type of interpretation in this case in most of these tissue areas. Again, we can see there's a little bit of villus type architecture in some of these tissues. And if they don't drain appropriately, then it's perfectly natural that some of this mucus and secretion would remain hung up in these cystic spaces. Here again, we can pick out another little island of immature cartilage right here with the blue matrix and moderate cellularity. So it does have immature tissues, but it does not have any immature neuroglial tissue, so it's a grade 0 or grade 1 at the very, very most, unless you have other tissues with more of this tissue. Here's another example, I think potentially showing us more of this type of mixed epithelial component. Again, some immature type of tissue here, a little bit more glial tissue, and this immature cartilage sort of surrounding these maybe trachea or glottis-like structures. More immature non-adult tissues here. So again, we look and search to make sure that we don't have glial elements, and certainly these type of tissues that have glial differentiation would be where we'd want to make sure we'd carefully sampled that and excluded that possibility. Here's more immature cartilage, maybe forming multiple ribs or maybe some extremity bones. And more cartilage up here. So a moderate amount of immature cartilage, but no immature neuroglial tissue in this lesion. So a variation on this are the monodermal teratomas, which include struma ovarii, insular and trabecular carcinoid tumors, and then the combination of these in the strumal carcinoids. This is a monodermal teratoma that has thyroid-like tissue, but it may be present as a component of a mature teratoma with other germlines, in which case you would report it as a mature teratoma with struma ovarii. This colloid tissue is often identifiable grossly and should be sought. And it's also important to note that some secondary thyroid neoplasms can arise from this tissue. With not infrequently the same molecular phenotypes as seen in primary thyroid lesions. So here we come back to our original case. We've already looked in detail at these epithelial elements. We glossed over this area here, which of course is a bad habit that I would not want to encourage. But as you see, we've got lots of colloid and intervening follicular epithelium surrounding this tissue. As we see, the colloid is nicely formed, a little bit of scalloping, and the nuclei are well spaced apart without significant atypia, clearing, grooves, nuclei, etc., nucleoli that would suggest the possibility of neoplasia. So a struma ovarii in mature cystic teratoma. And you'll encounter this in a reasonable percentage of cystic teratomas. Probably less than 10%, but not something that you would never expect to see if you're looking for it. Here's another example. We see lots of colloid tissue here, large cystic spaces, some areas where there's been some degeneration with cholesterol cleft formation. And these tissues, again, have a nice follicular lining cell type pattern with good nuclear morphology, no significant overlap or atypia. So in this case, no associated epithelial component to suggest cystic teratoma, but a pure stromal ovarii. Carcinoid tumors, of course, can occur, as I've mentioned, and may be associated with the clinical syndrome in a number of cases. There are several patterns that we may see, including goblet cell type lesion, which can mimic mucinous carcinoma. These usually have some element of teratoma present, and if not, then we need to be considering the possibility of metastatic neuroendocrine tumor, as well as primary ovarian carcinoid. The two most common lesions are the insular pattern, island-like, and the trabecular pattern, which is a little bit more commonly associated with the carcinoid syndrome. Here's an example of a tumor, and as we go take a look at this at higher magnification, we'll see this is not the typical insular pattern. It's little cords and strands of cells. And as we look here at higher magnification, we see these cells have sort of eccentric nuclei. Many of them here, I think we can see, have a little mucin type droplet in some of the cells. The nuclei are pushed to the side. So these are looking a lot like goblet cell carcinoid. So this is a situation where we would want to ask that question: is this a primary tumor, or is this a goblet cell carcinoma that has metastasized from the appendix? So while a tumor like this can occur primarily in the ovary, perhaps more commonly it would be a metastatic lesion, which is the case with this particular slide. I've mentioned the stromal carcinoid, the combination of carcinoid and thyroid parenchyma. And with this lesion, the main differential here comes from a differentiated thyroid neoplasm that has solid areas, which is then categorized as poorly differentiated thyroid carcinoma. And so recognizing that these tumors can occur in this manner is important, because that's an important differential not to miss. Here's an example of a slightly different scenario, a follicular type pattern, but this is a lesion which was locally invasive, and as we will see here, it has the morphology of papillary thyroid carcinoma. So although it's all follicular, we can see that there's nuclear overlap, clearing, and if we were to look very closely, we might find a few inclusions like right there. And there's some nuclear grooves, little nucleoli, all of the features from a nuclear standpoint that we'd like to see in papillary carcinoma follicular variant. Now the NIFPT, the non-invasive encapsulated tumor with follicular or with papillary-like nuclear features, has not been described or discussed extensively in the struma ovarii cases to date. But I suppose theoretically, it's only a matter of time until someone publishes an article asserting that that has occurred. A follicular lesion like this would certainly make you raise the question, but with the presence of invasion, that would be ruled out. All right, so let's go on to Disgermonoma, which is the most frequently encountered primary germ cell tumor with malignant potential. This resembles seminoma as seen in men, but it's much less common. That said, as far as malignant germ cell tumors go, this is the more frequently encountered. The immunophenotype, positive for several germ cell markers, SAL4, PLAP, CD117, and OCT3-4, but negative for napsin, EMA, D240, things that might make us think of embryonal carcinoma, clear cell carcinoma, and so forth. Or excuse me, positive for D240. The cytokeratins can be variable, but oftentimes have that dot-like staining characteristic of germ cell tumors. So here's a nice example. Very bluish kind of tumor, some clearing evident, a somewhat insular pattern. And as we come to higher magnification, we can see the characteristic morphology with nuclear atypia, centrally located, prominent nucleolus, clearing or frilly type cytoplasm, and a scattering of lymphocytes scattered in the trabeculae in between these cords of slightly cohesive cells. Now, it's easy to see this might be mistaken potentially for a juvenile granulosa cell tumor or something like that, but the lymphocytes are distinctive, and the degree of atypia and mitotic activity, those could be seen with a juvenile granulosa cell tumor, but you don't see the large follicular structures. You're seeing more of a solid type tumor. So the patterns are different, even though the differential consideration should pass through your mind. Here's another example, less well fixed perhaps, and so the morphology is not quite as good, and the number of lymphocytes appears to be lower. But we can see these not terribly well cohesive type cells, fairly monotonous, intermediate grade nuclei, not a great degree of pleomorphism, and the pattern with interspersed areas of fibrovascular stroma. And if we were to stain, we would probably find coming out of this background a good number of lymphocytes. The Oxact tumor is the next most frequently encountered malignant germ cell tumor. And this is a very interesting tumor that has a quite variable morphologic spectrum that resemble primitive endodermal structures. The most frequently encountered pattern, of course, is a very reticulated type of tumor with a little microcystic formation. And that usually will be present somewhere within virtually every Oxact tumor. Much has been made of the diagnostic Schiller-Duval bodies, but these are really only seen in about 20% of cases. So looking for them is great, but if you don't find them, don't be dismayed. You can still make this diagnosis. In addition to the reticulated pattern, we can see hepatoid patterns. We can see the polyvitelline duct pattern. And we can occasionally see more glandular type lesions that at times will resemble endometrial type carcinoma. So there's a secretory pattern. We'll take a look at one of those in a minute. These lesions tend to be AFB positive, both in the tumor as well as in the serum. So serum tumor markers are very useful. Again, SAL4 positive, glypican-3 positive, especially the hepatoid variants, but negative for OCT3-4, CD117, and D240. So easily distinguished on immunohistochemistry from both Disgermonoma and embryonal carcinoma. Although from a pragmatic standpoint, the immunohistochemistry is confirmatory, but shouldn't be the main diagnostic crux that you look for. So let's take a look at one of these. This one derived from, I believe we're in the testis here. We have a little reedy here and a little seminiferous tubule. So we can see that there is this slight glandular pattern and a little bit of reticulated pattern. We can see the cells have a degree of malignancy. There's prominent nucleoli. a little bit of myxoid stroma, and in this case, I would think immunohistochemistry would be useful and would help to confirm the diagnosis. But from a pragmatic standpoint, if this isn't a carcinoma, either metastatic or otherwise, then germ cell tumor should immediately jump to mind. And with maybe little Schiller-Duval type structures, a little bit like that, we might easily come to the diagnosis of yolk sac tumor and confirm that with immunohistochemistry, as we've just noted. Again, this is quite an interesting tumor to scroll through and get a feel for the different patterns. Let's take a look at another one. Here's a more classical one from the ovary, and we can see here this nice reticulated pattern of microcystic changes, small sieve-like patterns, interlacing nests and cords of cells with a lot of clear spaces and intervening vascular structures with generally thin walls. So this is the more classic pattern. Now, one thing that we can look for in these lesions are eosinophilic droplets. These are very commonly present in yolk sac tumors. They're not specific, as they can be seen in clear cell carcinoma and other tumors, but they're certainly helpful to think about the diagnosis when you identify them in these cells, these eosinophilic droplets. So that's another useful microscopic feature to look for. Here's another example, again drawn from the testis. And we can see this heterogeneous pattern, small microcystic spaces, easily identifiable malignant cells, a little bit more pleomorphic than Disgermonoma, and certainly having an architectural pattern that is distinctive from that or from embryonal carcinoma. So certainly anytime you get a tumor that has elevated, or a patient who has an elevated AFP and they have an ovarian lesion, you should be thinking about this tumor and verify that you have looked thoroughly to exclude the presence of an area of this type of tumor. Not all of these tumors will be pure yolk sac tumors. Very often they will arise in conjunction with other germ cell tumors or other elements of the tumor. But if you have the serum marker, you definitely need to be searching to find the tissue correlate. And as I've illustrated, these will be very similar in both the ovary and in the testis. Here's another example, again from the testis. We see this nice reticulated microvesicular sieve-like pattern of these cells, and ample mitoses, a little bit of atypia to these cells, eosinophilic droplets. All of these are very helpful features that should begin to jump out at you as you look at these kinds of cases. Embryonal carcinoma, in contrast, is a high-grade pleomorphic carcinoma that derives from germ cells. And these patients usually have both elevated AFP and a high HCG. It's distinguished from yolk sac tumor by the presence of a very high-grade carcinomatous element, oftentimes with associated necrosis. Although certainly in the testis, this is most frequently seen as a mixed germ cell tumor with embryonal carcinoma. But I think as we look at this at high magnification, we can see the epithelial type nature of this lesion. It's forming epithelial type structures and clearly has this high-grade malignant backdrop of necrosis, karyorrhexis, and so forth, with this variable glandular and papillary type of architecture with these variable spaces as we see here. Not usually a hard lesion to miss in terms of malignancy. Proper categorization and remembering that this type of lesion can be seen will help you to avoid making the diagnosis of high-grade serous carcinoma or something like that in a younger patient that more likely has a germ cell tumor of embryonal carcinomatous type. Here's another example. Again, lots of ample tumor, necrosis, and we see here areas of nice epithelial type carcinomatous differentiation, so certainly defining the carcinomatous element. This lesion also has a few areas like right here where we get this more reticulated pattern. As we see here, this is not characteristic of embryonal carcinoma. And as you see, the cells are a little bit lower grade here. So this may be an area of yolk sac tumor. Here we see a few eosinophilic droplets. And so searching for these kinds of areas would change the diagnosis from pure embryonal carcinoma to mixed germ cell tumor with both yolk sac and embryonal carcinoma present. So you want to search the entire viable tumor. Most of it here in this case is embryonal carcinoma. Now this is a pattern here, this very clear cell pattern that can be seen in yolk sac tumor. And sometimes it can actually resemble secretory endometrioid carcinoma. So this may, in fact, be a variant of yolk sac tumor here rather than embryonal carcinoma, or something that's slightly in transition. So here's where immunohistochemistry may be helpful in differentiating these two and seeing what marks in which areas. Choreocarcinoma resembles choriocarcinoma that arises elsewhere. It can present as a primary germ cell derived tumor, or it can arise in the ovary from an ovarian or tubal pregnancy. And so both of those considerations have to be considered and entered into your differential. Again, these patients will usually have a very high HCG, similar to what you would see in an ectopic pregnancy. Now here's a metastatic lesion from prior era when these lesions might have been excised. And microscopically, we see that it's a very hemorrhagic tumor, partly necrotic. And we have a mixture of two kinds of cells here. So we have these cytotrophoblastic cells, and then we have the syncytiotrophoblastic cells that tend to have multinucleated cells, somewhat smudged nuclei, and a more bizarre appearance. Here we see more of them here. Here's a few mixed in here. And of course, these syncytiotrophoblastic cells can be present in other tumors on occasion, but when associated with this hemorrhagic pattern and this high-grade cytotrophoblastic type neoplasm is best termed choriocarcinoma. Here's another case from the testis, as we see here, and we can see here nice evidence of embryonal type carcinoma. We've got some glandular spaces falling apart here. Although we might wonder about Disgermonoma, and certainly if we were to see very many lymphocytes, we'd maybe move more in that direction. But Disgermonoma is not usually associated with this degree of necrosis. Here you see more of the glandular pattern here. And then over here, we see this nice Disgermonoma, very fluffy, frilly cytoplasm type of cell, mixture of Disgermonoma, seminoma, and embryonal carcinoma. Now we may be able to find other elements here as well if we were to search exhaustively. This looks more like embryonal carcinoma. All right. Now, occasionally you will get a tumor that has a somatic type of, or excuse me, a mature teratoma, and here we see nice skin structures, smooth muscle, keratin, adnexal structures maybe here, or a different type of epithelium, more mucinous, columnar epithelium here. So we've got several different types of epithelium and this keratinization that's indicative of mature teratoma. And then as we look here, we can see that we have this very nice pattern that is looks a lot like endometrioid carcinoma. Looks a lot like secretory type endometrioid carcinoma, but this is actually the endometrioid variant of yolk sac tumor. And so this is a nice pattern. It's an unusual pattern, but it's a good one to be aware of, that it has this sort of subnuclear vacuolization that looks like secretory endometrium, but you've got more clearly malignant type cells here. And so this is an element of yolk sac tumor arising in a mature, arising with a mature cystic teratoma. Now you can see that combination very, very rarely, but certainly we can have other somatic malignancies that can arise in mature teratomas from the squamous elements, from the rhabdoid elements, from the glandular elements. All of those are possibilities. So this is just a very nice pattern of one of the additional variants of yolk sac tumor that looks for all the world like an endometrioid type tumor with this subnuclear vacuolization. So with that, we come to the conclusion of part 4. There's certainly more that we could cover in these tumors, but they're increasingly and vanishingly rare. We hope that you'll be ready for part 5 when we put that online in a few days. And that with that will come a more complete picture of neoplasia in the ovary. So until then, thanks so much for joining us. We hope that you'll subscribe. If you like this, please share it with your colleagues or others who may be interested. And again, I apologize if you started to watch this once without sound. Again, I missed that salary payment for my sound engineer, and we're glad that he agreed to come back for this version. So until next time, thanks for joining us.